afternoon, everybody, and welcome to today's webinar hosted by the Medicines Management Team and Let's Make Lemonade, which today is giving you an overview of involving people to manage risks, which is one of the quality statements that form part of the SAFE key question of the CQC's framework. For those of you that are new to these webinars, this is the 5th now in this year's series, and they're all with the intention of trying to improve CQC awareness and compliance for providers that work across primary care in particular. And we've had so far an overview of the whole SAFE key question, and then we're slowly, month by month, working our way through the quality statements one by one. All of the previous webinars have been recorded and are available for you to watch in your own time on the YouTube channel, which I'll ask Ben to put a link into the chat for you now. And at the same time, he'll also put a link in there for next month's webinar on safe environments if you want to be super keen and get registered for that one now. Just a little bit of housekeeping before we start. We've got the chat and the Q&A functions today, which are open. So do use those if you have any comments or questions as we go along, and we will try our best to answer them either as we go or at the end, or perhaps even afterwards to you personally. And thank you to those of you who submitted questions in advance using the registration form when you registered. We're really grateful for those. And we've collated some of those kind of key ones, and we will come to those at the end of the session and answer them too. The recording will be shared afterwards, so don't worry about taking notes. Starting with some introductions then, my name's Dr Clare Sieber. I'm a working GP and GP clinical advisor for the Medicines Management Team, and I'll be chairing this webinar today. I'll then let the rest of the panel introduce themselves to you, and hopefully you'll see from their experience that it gives a nice broad view of the CQC framework and its impact on us as providers and our everyday application of it in the general practice and primary care setting. So Gary, I'll come to you, and then if you could hand over to Mateen, then Rashad, and then Gabi, all for the introductions, and then Gabi will continue and take us through the main content of the webinar. Thanks, Gary.
Okay, hi everybody. Yeah, my name's Gary Hughes. I've been in primary care for 18 years. For 13 of that I was a practice manager. I've been a PCN board member, Federation Director, and I now support practices to help them be the best business they can be. Mateen, over to you.
Good afternoon, everyone. Absolute pleasure to be here alongside my colleagues. I'm Dr. Elahi, a GP for the last 6.5 years, a partner at Elm Tree Medical Centre. Today in this webinar as a GP clinical advisor to the Medicine Management Team. Nice to meet you all.
Hi everyone, lovely to meet you all. My name is Rashad. I'm a pharmacist and advanced clinical practitioner with many years experience in primary care. I also work as a director at the Medicines Management Team, which is an award-winning provider of remote pharmacist and pharmacy technician services to GP practices and PCNs across the UK.
And hi everyone, my name is Gabi Ashton. I'm a former CQC inspector and now a CQC compliance advisor and specialist. And yeah, I'm actually really excited to be here. I've been working in health and social care now for many, many years, but I left CQC in 2022, and I've been doing kind of mock inspections and CQC compliance support since. And I'm actually this week doing a focused inspection on the key question SAFE with a healthcare provider, which is proving really, really interesting and exciting. And one of the key trends that we are kind of unpicking is actually how we include patients in risk management and understanding their own treatment plan and the journey that they are kind of being advised on or kind of sent on. So this feels very timely, and yeah, really excited to be here. So I will just quickly move on to the next slide. So Rashad can give a little bit more information if he wants about the Medicines Management Team, and then we can dive into the quality statement.
Of course. So some quick facts about the Medicines Management Team. We are an established provider to the NHS for 8 years of pharmacy services. We're trusted by 85 PCNs and 250 GP practices. Essentially, we provide managed pharmacy support from our training hub, fully supervised by GPs and senior pharmacists. We handle all clinical, IT and HR queries. We can get up and going within 2 to 4 weeks, and it's fully within ours. So if you're a GP practice or a PCN looking to hire a pharmacist, get in touch and see how we can help you. Over to you, Gabi.
Brilliant, thank you. Okay, so we are here today to talk about involving people to manage risks. So in short, the CQC have said that this is where the expectation is that providers will work with people, so directly with the patients, to understand and manage risks by thinking holistically so that care meets their needs in a way that is safe and supportive and enables them to do things that matter to them. So as always, when we talk about these quality statements, we underpin it. We look at what the legislation that underpins it. There is a lot of talk around the current assessment framework. It's the potential to change. What does that look like? What does that mean? But we always try and remind people that from a fundamental standards and a legislative perspective, there are no changes. So we encourage people to familiarise themselves and make sure they're confident with the legislation, rather than the kind of changes in a future assessment framework that may or may not come to fruition at this stage. So there are three key pieces of legislation that we focus on. There is Regulation 12, which talks about safe care and treatment. And here the guidelines are very clear. So they say that assessments, planning and delivery of care and treatment should be based on risk assessments that balance the needs and safety of people using the service with their rights and preferences. So if the CQC were to come out and do an inspection and find that actually from a balanced and proportionate perspective that people hadn't been considered, hadn't been consulted or kind of taken along in the consultation and treatment plan journey, and that their rights and preferences hadn't been considered, then that would potentially lead to kind of a risk or a breach in Regulation 12, depending on the severity and the impact of their findings. Interestingly, this one's also underpinned by Regulation 11, which talks about consent. And here the guidelines say that a person with the necessary knowledge and understanding of the care and treatment should provide this information so that they can answer any questions about it to help the person consent. So again, the wording there is very clear that from a clinician's or non-clinical, depending on the nature of the inquiry, but from a treatment and journey perspective, the right people should be able to provide the right information to people in a way that they can comprehend, that they can understand, that they can receive, in order for them to be able to consent to their options and to their treatment plan. And we have had a couple of questions from a capacity and consent perspective, which we'll come on to at the end of the presentation. And then Regulation 9 is looking at person-centred care. So here the CQC say that a person's care and treatment must be designed to make sure it meets all their needs. There may be times when a person's needs and preferences cannot be met, and in these instances, providers must explain the impact of this to them and explore alternatives so the person can make informed decisions about their care and treatment. And hopefully that's something we can unpick today in terms of that concept of providing alternatives and looking at how information is made available to patients to give them a choice. We all hopefully understand the idea that it doesn't have to be, especially from a clinical perspective, it doesn't have to be the choice that you might think is the right one, but it has to be one that they've consented to and that they understand the implications for, and that part of the Mental Capacity Act and the principles that underpin that is that unwise decisions doesn't mean a lack of capacity. So it's taking that on board and making sure that care is person-centred. So like all quality statements, they are made up on the CQC website of then kind of numerous sub-statements. So we tried to bring those together, and then what we're going to be doing is looking at some extracts from CQC reports that have been published in the last month, ranging from outstanding, which are in blue, good in green, requires improvement in orange, and red in inadequate. And then we can kind of use that as some food for thought as we go through the webinar. So we've got here a good service. So the duty doctor was based in the reception area, meaning they were immediately on hand to deal with any emergencies there were and to support reception staff with urgent telephone calls. So again, when we're thinking about how patients are informed about risks, how they can be assessed, triaged, and so that everybody in the room can kind of understand them, and how the service are looking to take a balanced and proportionate approach, and making sure that risk assessments are done in a person-centered way. This is a very good kind of concrete example of how that can be managed. We've got another example here. So our patient records review as part of the assessment found that consultation notes were detailed, and we saw evidence of risks and side effects being communicated to patients. And that's positive, and many of you probably were reading that thinking that's obvious, and we do that, but it's surprising how little that is actually reported upon as a positive thing. And And in my line of work, it's not a huge, you don't see a huge amount of complaints, but you see enough for it to be a concern, where patients don't necessarily feel that they are aware of the risks or the side effects of the medication they're being prescribed or the treatment plan they're being offered. And actually, were there any alternatives that, yes, may not have been as effective, but may have suited them more from a person-centered perspective. And another good rating is, as part of our assessment, we received patient feedback about the service. The vast majority of patients reported positive experiences of using the service and told us that clinicians had fully explained their treatment, including risks and side effects. I think that's a really lovely piece of feedback, to be honest. And actually, as clinicians, hopefully that's something that you know, if you were to go away at the end of the day and think, if you were to reflect on what could your patients reflect on, and do they feel that actually everything has been explained to them? Is that something that you can go away and feel quite confident about, and then know that that's backed up by the quality and content of your record keeping? Then that's certainly a good outcome. Then we have here a outstanding service. So here they received a score of 4 out of 4 in this particular quality statement, and the CQC have said that as part of our assessment, we reviewed the numerous case studies demonstrating the impact of this service for patients. I'll talk about what the service was in a moment. And we saw that conditions such as leg ulcers, burns and addiction had been identified and addressed through this service. So, and essentially this is because it's a very long paragraph, so I couldn't fit it all on the page for you, but the practice essentially offered a variety of services to meet the needs of the local population. And that's a very, very key point as to why they would have received an outstanding rating, is because they had had awareness and shown an understanding of who their local population was and what sorts of treatments and care needs they would be coming across more than others. So this included an outreach vehicle, and it also had the outreach vehicle, which hosted a dedicated team, including a paramedic, nurses, an OT, and a healthcare assistant. And the idea of this was to engage with people experiencing homelessness and vulnerable people who would otherwise fail to engage with the traditional kind of pathway for healthcare services that we're used to seeing. It worked kind of out of hours, so outside of the typical 9 to 5. And it also looked to provide a full registration, to encourage registration at the practice. So it worked with people when we're thinking about accessible information, which I know we talked about in the past. So people who may require information presented in a different way or have different communication needs. It had worked in a very kind of conscious and proactive manner to address that and then support people to be registered at the practice. So this particular service is what then led to an outstanding rating for them in this particular quality statement. We've got some, we've got some inadequate and requires improvement feedback as well. And there is one that I'm going to get Rashad's thoughts on. I think I'll put him on the spot a bit, but in a moment. So the first one is inadequate. So this service received a score of 1 out of 4. So staff did not work effectively with patients to understand and manage risks. Our searches of clinical records show that the patients were not informed about risks in relation to their treatment and medication and how to keep themselves safe. So again, everyone on the call, I imagine, is reading that thinking, oh, we don't do that. We definitely wouldn't do that. That's obviously very poor practice. But actually, my critical friend question to you would be, how do you know? So when was the last time that you did do your own internal audits or quality assurance reviews of your clinical records to make sure that they were comprehensive and did demonstrate the quality of care that you're hoping to deliver to people? It requires improvement. So we've got a couple here. I'll just go to the bottom left one first. So because actually from the same service. So the provider had not undertaken a local risk assessment to determine the required emergency medicines to be held within the practice, and not all the recommended emergency equipment and medicines were available, nor had they documented any steps to mitigate the risk of not having these. And we also found that patients were encouraged to choose products from the entire formulary offered by a partnered pharmacy, with no guidance on what types might be most suitable for their condition. So these selections were not reviewed by the specialist responsible for the patient's care. So I'm going to put Rashad on the spot here before we move on to the next one, just to get his thoughts from a prescribing and kind of pharmaceutical perspective, particularly around, this idea that, that emergency medicines haven't been considered or risk assessed. And I just wonder, Rashad, is that something that you come across from a medicines management perspective? But also this idea about the formulary and the partnered pharmacy and the lack of guidance available for patients to think about what might be more suitable for their condition. Just wondered if you had any thoughts on that.
Absolutely. I think local formularies and guidance varies across the UK. So it's important for prescribers to be aware of the local formulary and know what to prescribe. Generally, don't ignore alerts on the clinical system. So on EMIS and System 1, if you prescribe something that's not in the local formulary, it'll flag up. So don't ignore that warning and accept the request to prescribe a suitable alternative. So I'd always advise that. And in terms of emergency medication being kept in the practice, I'd recommend keep it stocked up, make sure nothing's expired and it is available and to hand, and have a specific person whose responsibility is really.
Yeah, fantastic, thank you. And actually, we will include this guidance as part of this presentation. So I think slide number 11. But actually, the CQC have very recently, I think maybe in the last few weeks, maybe 6 weeks at the most, have updated the Mythbuster on emergency medicines in GP practices. So there is updated guidance available for people to refer to if they haven't yet had a chance to do so. So that you'll get that in the slide, or just look up. Hopefully everyone's familiar with the CQC Mythbusters. So if you just Google CQC Mythbuster emergency meds in GPs practices, then that will come up for you. And then we've just got a couple more reports to think about. So this is focusing on, so one of the kind of sub-statements within this quality statement is when people communicate their needs, emotions or distress, staff can manage this in a positive way that protects their rights, their dignity and maximises learning. So we've got here a good rating. Patients reported they were involved in their care. In the 2025 National GP Patient Survey, 86% of respondents reported being involved in decisions about their care, with the national average being 91. So that's pretty good data overall. And here we did not see guidance, including visual tools available to enable staff, including reception staff, to identify a deteriorating patient on reception during the assessment. However, leaders told us that they did have them and would locate them and return them to reception following the assessment, which the CQC received confirmation of. This one just made me laugh really, because the CQC have been, so the CQC, it is a shame. There is variation, I suppose, in the response that's taken in situations like that. That could equally just have been a requires improvement, and you may get an inspector who says, well, yes, you put it back, but actually it wasn't there. How long has it not been there for? And I'm sure Gary might be so kind of smiling on the inside, because this is something that from a practice management, from a kind of support team, is something that it's very easy to get right, but it's also very easy to let slip, and things like that, if they are picked up on, then it won't always go in your favour. So just making sure that as part of your daily walkarounds, you are making sure the information that you do have that is useful, positive for your colleagues, is available. And if it's not, don't wait for the CQC to identify that it's missing. Try and put it up as soon as you notice it's missing. We've got here, this is the last part of the quality statement, but this is actually unlike it wouldn't be relevant in GP practices, but we may have some people in adult social care that are on the call as well. So this pretty much focuses on the use of restraints, so which you wouldn't, you'd see in adult social care settings more than ever. And it also does talk about equality and human rights legislation to be considered, but again, that's very much from a restricted practice perspective. So in terms of some top tips for people, and some guidance, it's all based on best practice guidance that exists out there. We thought we'd just share a slide on co-production. So the statutory guidance on working in partnership with people and communities, which is available kind of, live and kicking and available for anybody to have a look at, does place a legal duty on organisations to make sure that people are appropriately involved in their planning. And it sort of mirrors it sort of sits alongside the accessible information standards, which is also a legal obligation and legal duty for providers to adhere to make sure that information is made available. But I have talked a lot about accessible information standards before, so I'll try not to bore you with that one today. But yeah, the co-production principles essentially is a blended approach working in partnership with people and communities. And there are 10 different principles. There are 10 principles that this kind of guidance gives on working with people. And so there are 3 that sort of stand out when we're looking at this in more detail. One of them is involving people and communities at every stage and feeding back to them about how their feedback has then influenced activities and decisions. This is something that I'm very, very you know, I'm always quite keen to unpick when we do mock inspections or when we meet with providers. You know, we'll all be familiar with the term closing the loop from a communications perspective. And actually, we don't always see the loop being completely closed in this sense of, you know, we welcome feedback, we look forward to feedback, we document it, we put it on a tracker, we discuss it internally, we make changes. But the final step of actually then going back to the person or the people that have given the feedback in the first place and acknowledging with them what the changes have, you know, what changes have been made and how they have influenced, you know, outcomes of, you know, potential outcomes for care and the quality of a service. That is the one stage I'd say isn't consistently met or isn't met at the same standard as all of the other stages of co-production. So, you know, for yourselves on the call, just kind of thinking, asking yourself again, do we do that? Do we do that final bit of that bit of the puzzle to make sure that loop is closed? I would, you know, I'd consider. Another principle within this, within the working together, working in partnership guidance is understanding your community's needs, experience, ideas and aspirations for healthcare and using engagement to find out what this is and if change is working. So we'll see from the outstanding service that the report that we looked at a few slides back, that actually if you do really get to the bottom of who your local community are, what the needs are, rather than taking a sort of standard and general approach to healthcare, then it can only lead to better outcomes for people. And so the CQC, or, you know, anyone would be keen to hear about how you've gone about, so kind of what engagement activities you've used to ascertain what your local needs are and what you've then done to try and address that. And I think that idea of unpicking what aspirations are for people's health and care is quite an interesting one. You know, I'm not necessarily the expert in that particular area about unpicking aspirations, but it certainly sounds like something that you know, is quite lovely. Don't think I've ever been asked that question by a doctor. But yeah, I think understanding that the local needs is definitely a good place to start. It also talks about using community-centred approaches, so making connections with what works already. And I know we have talked in previous webinars about partnership working and building those connections. And, you know, we've talked about, for example, having guest speakers in at a local as well as a specialist level, you know, liaising with existing health and social care services that already operate, you know, that whether that be statutory, voluntary, in whatever capacity they exist in the local area, how can we bridge the gap and bring health and social care and the local community together is worth thinking about. And then the kind of the last principle on there is learning from what works. So again, it sounds obvious, but actually taking the time to look around you and see which services are succeeding, which services are thriving. We know which services in the local area are closing down, you know, potentially due to funding, but also potentially just due to lack of uptake, lack of interest, maybe that it's not relevant to your local area. And taking that learning on board and then building from that, so building kind of out from that to make sure that your service has considered local need. And all of those concepts feed really nicely into the co-production principles and the co-design principles that we are all aspiring. I know lots of you will be thinking it's an aspiration. So yeah, it's certainly something to aspire to from a health and social care perspective. So here we've just got some links that were made available to you, the top 5 kind of best practice links that are available kind of deep within the CQC. So I thought we'd best just bring them onto one page for you. So you have emergency care in general practice, you've got suspected sepsis in people aged 16 or over, and then the under 16s as well. And then looking at suspected sepsis in pregnant or recently pregnant people. And then there have also been some updates to the resuscitation guidelines that were made in 2025, but it was quite a while since those changes had been made. The previous ones were 2021. So these are all worth double checking, reading, and making sure that you are familiar with, and that your policies, your procedures, and that your guidance reflects up to date and best practice. It is something that, you know, we recognise can easily kind of, although say fall behind on it, might be that the clinicians, you know, they're working in the most up-to-date way, but making sure that your policies, your procedures, your SOPs and your wider team awareness, so thinking about your training, etc., are all up to date with the most common, recent guidelines. Okay, so we're going to move on to questions now. We've got a few questions for Gary, Rashad and Mateen as well. And yeah, then we'll go on to questions from the audience. So hopefully this will be interesting. Right, Gary, first one for you. So we can see from the outstanding rated service that the community work that this practice did was quite extensive. So we want to look beyond that to this feedback from the CQC about case studies, because that was a very good example of a case study. As an inspector, a previous inspector, I always value case studies, so I love them. I think they paint a really good picture. They make it easier for providers to present good or outstanding practice. They, if people are feeling nervous, if they don't feel they've got enough evidence, then case studies can be a fantastic story to unpick. From a practice manager perspective, what are some top tips you would share to ensure that case studies can be achieved, created, used, and have impact?
Okay, thanks, Gary. I think case studies are a great idea. I'm going to be honest, actually, I didn't do what I'm going to say to do now. I think it's the benefit of hindsight, but I think they're a great idea. And I suspect a lot of times they're not done or not done well is because they just feel like they're too time consuming or too difficult. But the thing is, and the impact that you ended that with is they do make the stories and the evidence that you're giving to the inspectors real. So they're absolutely worth doing. And I think there's three key things. The first thing I'd say is create your own case study template, because it tends to be that you sort of gather that story together and it's maybe not communicated in the right way. It doesn't make it easy to collect everything. So I'd create your own case study template to use. I'd make it specific, your case study. Not that, we've identified a safeguarding concern, but, here's the patient, here's what we noticed, here's what we did and why, and here's what changed, what we learned and changed as a result. And I do it all of the time. And we've through these webinars, we've always said about, make meeting your CQC standards a regular thing and not just 2 weeks before inspection. So do these all the time. Keep a rolling log of case studies throughout the year and share that responsibility in the same way you might do with your audits. And the practical tip I'd give practices is you don't want everything to be a case study, but you want to be on the lookout for the ones where the processes, where your processes made a real difference, and build that case study from that. And I'd use a simple template structure, like I said, that is maybe, what was the situation? What did the team do? What was the outcome? And what did you learn or change? And you can build that in a PowerPoint, a Word document, an MS Forms, however's best for you, but have a same consistent template that helps you give the evidence, tell the story to the inspectors when they're in as well. And when you have your inspection, make sure you're briefing the whole team. You want to make sure that everybody is telling the same case study story in the same way, and that's why the templates are a great idea. To just make sure you brief the team, everyone then tells the same story in the same way, same learning outcomes as well. So that's my top tips.
Brilliant, thanks, Gary. Yeah, I think you're spot on. They are seen as maybe a nice to have or a little bit of a burden when you've got your day-to-day, the amount of day-to-day operations that you have. But if you can find a way to include it, so with the kind of fundamental and simple template that Gary suggested, and have it as part of your monthly team meetings or your protected learning time, and just keep it as a rolling concept, then it will become ingrained, it will become natural to the organization. And actually, and it's not, as Gary said, it's not just for the CQC. This whole webinar series is very much about quality improvement and trying to make life easier for people, but in a way that also promotes learning and promotes kind of professional curiosity as well. So so we would definitely recommend, if you can, to try and include those. I can see that Claire's got her hand raised.
Thanks, Gabi. I was just wondering whether practices could kind of lean on their PPG a bit with this one as well. I hope that doesn't sound sort of too lazy of me, but you could ask your PPG, since they will be giving you feedback, and then being aware of what changes you have implemented as a result of their feedback, to kind of keep a basic log of everything that they've asked for, that you've given, and put the onus on them to keep that and maintain it, and of course share it with you. But that might just cut down on the work that probably the practice manager will have to do. Yeah.
Yeah, I think that's certainly an element of that. I wouldn't necessarily encourage PPG to do all the case studies, purely because some of the learning can come from internal processes. So it might be that maybe you alternate, so that the PPG maybe do every other, and then you do one as well. But yeah, it's certainly a good use of resources, and you know, their feedback will be invaluable. Gary, what are your thoughts?
Yeah, just to sort of add to that, what Claire's saying, in terms of delegating the workload, if you create a template and everybody knows where it is, it absolutely should be something that the GP, the nurse, the receptionist, the pharmacist, any roles, that if they've got something, they can actually create it. And it probably would be a good addition to have on the template, what do the patients say as well? What's their perspective on the case study? So leaning on your PPG from that point of view, great idea. I would imagine as an inspector that would be good to see.
Yeah, fantastic. Yeah, they are. I mean, I always love reading a case study, and it doesn't matter how they're presented, but as long as they tell a story and demonstrate impact, then they're always really, really, really helpful for everyone in the room. So okay, great. Martine, inadequate rated services have a theme. And what we're seeing is a theme in relation to clinical searches not showing that patients are informed about risk in relation to their treatment plan. So that's just from kind of reading recently published reports, and that theme is trending. As a GP, you must get note-making fatigue. I know I've been surrounded by doctors for a long time, so I know that there is that concept of paperwork and writing and bureaucracy, etc. So are there any formulas or prompts that you can use to ensure your notes are comprehensive enough? And I think it's going back to that question at the beginning of, you may feel confident that you are consulting and that you are advising and that you are having a kind of collaborative approach, but can you go home at the end of the day thinking, and my notes prove it?
Yeah, I think firstly, I think we have to think about the structure of the organization you're working in. So let's say if we're talking about primary care service or a GP, is the partnership, if you're a partner, is the organization providing you enough time to do your consultation in the first place? So you could be a GP registrar, you could be a nurse practitioner, etc. And do you feel comfortable in dealing with the patient population and their concerns in that consultation of time? And if you don't, then raising that with the appropriate people. And let's say you do have enough time, or you want to streamline that time. You need to be, we always as clinicians have to balance essentially safe documentation with time pressure. That is the case, isn't it? And over time, I think what I've learned is that good note taking is less about writing more, but it's writing the specific things that the consultation or documentation is required more than anything. So I tend to have a simple framework where, what did I discuss? So brief discussion, what options were considered, and always have risks involved, the pros and cons discussed with the patient. That's very important. And then red flags explained. And then just having a structure to it. And I think Gary mentioned about templates as well. So on System 1 or email, I'm not sure about emails, but on System 1 specifically, you can have a template consultation. And I know most of our salaried doctors have templates for sore throat, cough, abdominal pain, all those type of things. And even safety netting advice can be templated in some regards. Obviously, you need to change it specific to a patient. But the last point I want to talk about is the shared decision making. It's a consultation. You're not telling the patient what to do. It's a shared decision that the patient has to agree with as well. So the patient should be able to understand why that treatment has been advised, side effects, pros and cons, and alternatives discussed as well. And I think from a governance perspective, good note taking, yes, it protects the patients, but it definitely protects the clinician as well. So it's about continuity, especially with multiple professionals involved. I know I've worked in private care and primary care and GP land in NHS, and primary care isn't the same as 20 years ago. Your GP isn't your GP anymore. You end up seeing different types of GPs, different clinicians every time you go in. So that clarity in documentation is required more than ever. So having templates, having red flags in there, and shared decision making is probably the key.
Thank you. I'm curious then, because your answer it sounds like the systems set you up to have templates. You can take into consideration the time required. You can keep things concise. Why do you think that we are still seeing services rated poorly for this particular area then?
Different things, isn't it? But I think when you're set in stone, unfortunately, from the start, and you start documenting, let's say 4 lines per consult, then you're only going to go down, really. You're never going to go more than that. So it's a bit of I guess habit, I would say. A lot of it's due to patients coming up with multiple issues, multiple concerns. The amount of consultations in primary care is increasing. The amount of concerns is increasing. The average age in the population is increasing. Multi-morbidity is there. So the pressure on primary care as a whole is a lot more. So you want to do as much as you can for the patient, so you don't get enough time to then document. And regarding templates specifically, those tools are there in the electronic health records, but how many people are still using them? I'm not 100% sure. I know our salary doctors, 60%, probably 70% are using them, but the other 30% aren't. And I think the one other thing we haven't discussed is, AI scribes, etc., and documentation. They do speed up the documentation, but we tried to adopt it, piloted it in our practice, but it didn't really go down well. None of us are using it. It just didn't help us in any way. And then the last aspect is how many people are open to change. When we talked about when I'm talking about the habit at the start, when you're in a habit, how many people are open to at least piloting a change, be it templates, be it AI scribes, be it anything else. So I think all of those factors probably play a part.
Brilliant, thank you. Okay, Rashad, moving on to a question for you now. So the requires improvement rated service who received a score of 2. This was due to a lack of information provided to the patients about medicine suitable for their condition. So at the medicines management team, as part of your review, how do you look beyond the scribing, so the prescribing, so the fundamentals, and actually do you look at the information given to patients to demonstrate that they have been allowed to make an informed decision and that everything's been explained to them? And then in terms of guidance to be made available to patients, do you have any top tips from a prescribing perspective?
Good question. So I think essentially it always goes back to when the clinician first starts. So the training, the upskilling, the auditing, the appraisals, is that happening? So with those, we provide a managed process. So our training happens when a clinician joins us. They work from our training hub. So we control all the variables, which is consultation skills, styles, which templates to use, which read codes to use, specific counselling points. So it can be hard for clinicians to remember the specific counselling points for each drug, and there's so many. So we have aids there that remind our clinicians which counselling points to cover for each drug, and we audit the process. In terms of supporting patients to make informed decisions, what I recommend is providing balanced information. So don't be overly pushy. Sometimes it can get tricky in practice when you have PCN targets for medicines optimization. It's always important to give a patient a choice and shared decision making. Keep communication simple and personalized. Use decision aids. So NICE guidance, they have loads of really helpful patient decision aids that you can text the patient. Use questionnaires. This just helps the patient reflect and make a decision. Use technology. Send videos to patients. So I'm always, during consultation, if I do an asthma review, I'll text the patient inhaler technique videos and decision aids. My key advice would be don't let targets drive behaviour in terms of consultation skills, rushing consultations. Ensure you have adequate time and safe workflows to deliver the care properly. I think Dr. Mateen touched upon this. It's important for any workflow that's allocated to you, you have the correct amount of time, because if you're rushing, you're going to make mistakes. And one thing my tutor taught me was documentation is essential. So you can do a really amazing consultation, everything's perfect, but if it's not in the notes, it didn't happen. Because when CQC come around, they can only see your notes, so they can't see the amazing consultation that took place. So if the read codes are not there, you haven't safety netted according to your notes. Even if you've done it, it hasn't happened. So use templates. Ardens have amazing templates. You can create your own on eMissing System 1, and it reminds you the counselling points as well.
Brilliant, thank you. That's really, that's very detailed and really insightful. Yeah, I like the idea of these kind of the decision prompts and questionnaires that you can send in different formats as well. So the videos and other ways in which you can communicate afterwards with patients. Yeah, as an end user, I'm familiar with getting lots of texts after a consultation, but I don't think I've ever had a video or something that's a bit more accessible. So yeah, that sounds great. I'm just looking at the okay, thanks, and teams answered that. So next question for Gary. In terms of meaningful co-production, beyond the you said we did board, which everybody loves, have you seen any good examples of information being provided to patients to demonstrate how their feedback has shaped the service?
Okay. I mean, the first thing, I think the you said we did boards, I think they're a bit cheesy, and I'm not sure that they have the same amount of credibility as, say, the case studies that we've just talked about. And I think the practices that do co-production really well, they go further than just displaying the feedback that they've had and their response to it. What's better is involving patients before things go live, not reacting to it afterwards. So even if you get a small group together, and I can remember doing this with our PPG, get a small group together to give some feedback, some advice on, say, a new digital pathway before it launches, that's better co-production. That's real co-production. And then afterwards, ask your patients for feedback on specific things, not just we want feedback or wait for it to come. Just what tell them what you did and ask for feedback on specific things about how they feel about it now and what's happening. I've got a bit of an example from when I was in practice, and it was to do with a redesign of our website. And this is a while back, before sort of eConsult and things like that. But we wanted to make sure that it would work for blind and visually impaired patients, and also that we were able to explain how it would work to those patients. And we had a blind patient who was very, very engaged with the practice. So I went and spoke to him. I reached out to him and spoke to him. And he was able to make some suggestions and offer some advice that helped with the design of it, but then also helped our reception team explain it to patients who would have similar visual impairments. And it's a small pocket, but it was genuinely a patient sort of helping with the design. But here's a couple of thoughts for you. And it's, if you want to be sort of really bold, how about, in the same way that you might have a practice away day, how about having a patient away day? How about having a facilitated away day, get a small patient group in and help with that? Or if you're a PCM with a board or a federation with a board, how about having a patient member on the board?
I love it. A party.
And I know in saying those last two, and I've deliberately been provocative, I know there will be people on the call will be like, oh my God, I can't think of anything worse. But actually, there are huge benefits in if you do it properly. As a facilitator of away days, I think facilitating an away day with a group of patients to help designing services and the patients to get to know the surgery and vice versa, I think, bold, brave, hugely beneficial. I'll shut up now. Thank you.
No, I love it. I'm laughing because I agree. I think it's kind of a concept that I've never heard of it, and I love it, and I would love to see it. So perhaps you can start doing them, Gary. You put yourself forward.
Absolutely.
We just need a GP practice to raise their hand, and then Gary will be down there. So no, but I think in terms of meaningful co-production, it's a fantastic idea, and I think the you said we did boards are becoming very, very kind of old hat, aren't they? And a little bit redundant, especially when they're not updated. As someone, I've got a little one, and so I have been to the GP more times since he was born than I have probably my whole life before that. And so I do notice that the you said we did board hasn't actually been updated in about 2 years. So it's almost like when you go to restaurants and they've got a soup of the day, but it's the same every day for the next 6 months. So keeping co-production feedback alive is very, very important. Otherwise, we just look at it and think, what is the point? And giving feedback. So next question, final question for Mateen. Can you share an example of where patient feedback has changed the way that you work for the better? And then thinking beyond your own personal development from a GP perspective, how was this then shared with colleagues to ensure a more holistic approach to improvement?
Patient, yeah. So one of the biggest patient feedbacks that we saw when we adopted digital digital triage, into our clinical system, we actually notoriously had very good access, very good waiting times. But we tried to push towards the digital triage. We went quite heavy, making patients aware that this was going to happen, involving patients in it. But we didn't get the most positive feedback straight away. In the first couple of weeks, people weren't happy with the amount of times personally it was taking for us to come back to them. It was taking about a few hours to up to a day to come back, and they weren't happy with that. So we changed. We contacted the PPG, even though we had beforehand as well. We got the representative chair to come and talk to us, and we made amendments. Amendments mainly were to open up the phone lines again and have a hybrid system, essentially, where patients could have access either way, not just digital triage mainly. And I think most of the feedback that patients are going to be concerned about the most is going to be from the operational aspects. So I think I can remember another recurring theme, when people are talking about clinical care, they're worried about what could happen next from the GP point of view. I think what notoriously, I remember a few patients coming to us. We get really, really positive feedback on Facebook groups, etc. Whenever a person says which practice to join on a Facebook group, in that population, people say Elmtree Medical Centre and Elmtree Medical Centre, and then we often realize after 10 comments of that, the 11th comment is, please can we stop talking about Elmtree Medical Centre, otherwise they won't have the capacity to provide the quality of care that they are. And to reassure patients that yes, we are growing in size, but we are able to provide that, then you have to reassure them that yes, we can do this, and then go to the PPG, inform our websites that we are still accepting patients and that we are able to grow, and then getting patients involved in as much as possible. So our social media team has been very active in letting our population know, patients know, that a new member of team has arrived. We do some videos, including the partners, doing 2-3 minute intro videos talking about ourselves, getting them familiar with us, so they build that confidence that we are able to provide the service and we are able to listen to you as well. Often patients comment on our Facebook groups and social media, and we listen to them and we try and take that back in our management and make changes internally that way as well. So it's more of a holistic thing. There are several examples that I've shared which have impacted the way we operate and deliver service.
Brilliant, thank you. Yeah, I think that's really interesting. It's important as well. You've highlighted that you've got lots of different channels for feedbacks, but particularly through social media. And what I've actually seen on a recent inspection that I've done is complaints or feedback aren't tracked outside of the formal complaints process. So if any reviews are left elsewhere, then yes, they're responded to by the team, kind of, thanks for your feedback, we'll take this on board, etc. But then there's a gap. They're not then taken to the next steps. They're not added to the track, and they're not analysed and responded to in the same way that a formal complaint is. And actually making sure that you do have that holistic and comprehensive approach to feedback, so that whatever channel you receive information from is then managed, is really important. So, and you need to have the resources for that. So, don't open up those channels of communication if you haven't got the resources to then receive it and respond to it. So, as you said, kind of building slowly but surely from a quality perspective is really important. So that is the end of the specialist questions. We're just going to see now. I can see there's a couple of questions. We have got some questions on the next slide that we've received in advance of the webinar, but I'll hand over to Claire for some sort of end of webinar reflections and see if anybody else has a question they want to put in the chat.
Thanks, Gabby. Yeah, let's give people a minute to pop in the chat, but if you could flick to the next slide, I think there's the ones that were pre-submitted in advance by some of the people who registered for the webinar, which we'll come on to in just a sec. And we've also got the one in the chat that we've said we'll respond to next time, because that was all about Heidi, which is an ABT, and what the CQC's take on that is, which is going to form a lot of the discussion on next month's webinar, because that's all about, well, that's covered under what the CQC terms safe environments in their quality statement. And we got some actual digital experts on for that one, so we wouldn't do it justice if we answered it now, but we will do it in a lot of detail next time.
Okay. So one of the pre-submitted questions we got was, what would CQC see as a proportionate and defensible approach when a practice has taken reasonable steps to involve a patient in managing their own risks, but the patient does not engage or declines the safer route? This is very, very hopefully a fundamental response, in that if the patient has capacity, and Claire and Mateen and Rashad in particular from a clinical perspective can intervene here, but yeah, if the patient has capacity to make a decision and they make an unwise decision, then there's nothing you can do. As long as you've documented it, you've explained to them what the risks are, as you said, discuss side effects, but they've decided to choose a different route, then that there's nothing the CQC can do, basically, in a nutshell. So that's my very, very short answer. If anyone else has anything to say, then you can, but hopefully that's reassuring.
I would agree, Gabi. Patients are, of course, allowed to make bad decisions if they have the capacity to do so. We just need to document that. There's even actually a SNOMED read code that is shared decision making, which clinicians might like to use to sort of put into that consultation, as well as a kind of formal, more detailed documentation of what was actually discussed. But essentially, yeah, so long as you're involving the patient in managing their own risk, it is up to them how they choose to manage it, with the exception, of course, that if this is about prescribing something, you're the prescriber, so you have to make sure that you're prescribing within what you feel is your own kind of level of competency and safety that you can take on as a prescriber. But if this was, say, somebody declining a medication, then that's on them.
Yeah, basically. Okay, what would you expect patients to know about managing risk? What information would be useful to share with patients? So hopefully we've covered this in this webinar in terms of the different advice and guidance that particularly Claire, Rashad and Mateen have given from a note-taking perspective, from a proportionality point of view, from the nice prompts and guidance that are available. But I don't know, in terms of managing risk, I don't know, actually, maybe Claire, that's something that you could, I'm just looking at that thinking, what information would be useful to share with patients as much as possible is what I would say about the potential risks, so they can then make an informed decision. But I'm not sure kind of how to expand beyond that.
Yeah, I agree. I'm not quite sure what the question is asking, but I think the expectation is on us to provide the patient with the information that they need to manage the risk, and then it's up to the patients, providing they've got capacity, to do so themselves. And we can provide the information in written formats and followed up afterwards with text messages, with leaflets and videos like we've suggested.
Yeah, I think that's it. And share it, making sure that you are sharing with them in a format that works for them. So making sure that you've covered that as part of your face-to-face or remote consultation, that there is the follow-up engagement that they may need, that's covered in your consultation notes. But essentially, they just need to know as much as possible so that they can then go away and think about it and make an informed decision, is what we would say. This is a slightly similar question. What are some practical ways that primary care teams can document shared decision-making around risk in line with the CQC expectations? So I think Claire just mentioned that there is a shared decision-making template, and we've discussed different templates today. So hopefully, again, that's been covered. But if as part of these questions you do want any more detail, then please email us, and we will obviously provide kind of a more detailed answer. But hopefully it's been covered. And then, how would be the best way to do this for people living with dementia who do not have capacity? So I'm thinking, so how would be the best way to discuss to make the person who lives with dementia aware of risks? So from a risk management perspective, and information to share with the patient. So I think the point here that I would say is that you need to be clear what they lack capacity on first. So capacity isn't just a blanket approach, it's a decision specific concept. So you need to be, if we're saying that they lack capacity to make a decision about their healthcare and treatment, then you need to be looking from a legal perspective. So who are there? Do they have an LPA in place? Who is it that you would be liaising with to make that joint decision in their best interests? But you need to go down the MCA route first and kind of ascertain that they do lack capacity in that specific area, rather than just a blanket approach. And then thinking, I suppose I would be thinking about making information accessible in other ways if possible. So you know, if they lack capacity in one particular area, but actually they can still comprehend some information in a different format, then making sure that you do your best to meet those needs so that you are taking a holistic approach. And yeah, liaising with the person who then has legal responsibility or kind of legal duties to support them from a health perspective.
Yeah, I agree.
You
know, yeah, thanks. I agree. I mean, it then the decision making then falls on somebody else, not the person who doesn't have capacity. And so that person is the person who needs to be involved in knowing the risks so that they can make the best decision. And I guess the role of the GP or the clinician there, who presumably has had lots of continuity with this person over the years, can then provide some sort of individualized information to help that person who is making the decision make the decision on behalf of the patient.
Yeah, and I think, you know, we do see circumstances where again, from a decision-specific perspective, you can even kind of go more nuanced within, do they have capacity to understand the healthcare and treatment plan? Because, as I said, there might be some parts of the conversation or the communication that they can understand, such as communicating about pain or pain relief or other symptoms or side effects. But then there may be kind of the larger decisions about a treatment plan that they can't consent to due to lack of capacity. So it's really kind of unpicking that with the person who has legal responsibility to make those decisions and have that joint approach with you, and just making sure that you're doing the best, you know, that everything you're doing is in the best interests of the patient, is what I would say. I'll hand over. Yeah, I think that's everything now. We can wrap up.
Thanks, Gabi. Well, there we are. Impeccable timing. We've got 1 minute left. So I hope everybody found that webinar useful. It's great to see the numbers and everybody sort of staying on until the end. The next webinar is just in a couple of weeks' time. And as you know, we'll be talking a lot about AVTs and AI, but other things as well.